Hi everyone, my name is Adele. I'm 16. I want to tell you about bipolar disorder, also called manic depressive illness. I think many of you have heard of it, but just a few know what it really means. Bipolar disorder is about frequent mood swings. You can feel just great in the morning, depressed and willing to die by afternoon, and great again in the evening. And that happens over and over every day. Some may say they know exactly what it is from their own experience. In this case, either you exaggerate or you are really sick. This condition is not normal. I realize I'm sick, but there's nothing I can do about it. In my case, bipolar disorder began to progress several years ago. When I was 14, my dad got into an accident and died. I was enormously stressed. I loved him very much, and his death changed my life. That's when it all started. Depression, followed by mania, seemed a never-ending story. Since I was never stable, studying was a real pain, but I had to do homework and learn new things every day, regardless of my condition. When I got depressed, my whole body was frozen. I didn't want to eat or drink. I wanted absolutely nothing. My life was getting grey and boring. Everything seemed monotonous and dull. In such moments, I just spent time alone in my room and if often came to suicide attempts. Mania was the opposite state. My activity increased by 200%. At the same time, I couldn't concentrate on any particular subject or action. I wanted to do everything at the same time. I didn't know what to do with that much energy. I couldn't even stand in one place. And it is really scary. There's no balance or the middle. I'm always in some extreme state. And that bothers me. I mean, it used to bother when the condition was severe. I was having hard times and was about to have another major stress. But my mom took me to a psychologist. The treatment I received was long and complex, but I felt better. The good news was that I could control my disorder, and I found an alternative. When I felt sick and thought of suicide, I wrote essays about the meaning or meaninglessness of life and just my thoughts on various topics. After, I switched to poetry. I enjoyed writing poems. Sad and deep. They were a great tool to distract me from depression. I even learned to benefit from my mania. I tried to channel my energy into something useful. When I was at home, I was doing household chores and studying. If I had free time, I was doing workouts. I was also looking for some sport that I would enjoy, and I found it. It was volleyball. Soon, I became the best player and began to participate in competitions. I have a lot of medals at home, which I'm proud of. I'm very grateful to my psychologist, He really helped me. He pointed me in the right direction. But as he said, it was me who had to do the hard work. I did everything he advised, and that explains my progress. We both did a great job, and he was happy for me. Now I see myself in sports and poetry. I never knew I could do great at both. I also helped my mom learn to cook and clean. When I have time for myself, I master new skills, origami or sewing. I also want to become more flexible. Every day I do splits, and they will be perfect one day, I'm sure. My life has changed dramatically over the past few years. From a close and desperate person who couldn't get along with own self, I turned into a strong and committed girl who is able to cope with challenges. After all things I went through, I no longer fear difficulties. I overcome them easily. My message for you is that my path was not easy. I had to overcome laziness and fear, but it was definitely worth it. And if you ever find yourself in a difficult situation, my advice is to never give up and believe in yourself. Remember that you are the one responsible for your life. Thanks for watching, like the video and subscribe to the channel. Write in comments what you think about bipolar disorder. Have you met people with this condition?
So, good morning, everyone from the United States. I am Dr. LaKeonda Jefferson, presenting to you guys for International Women in Psychology. Today, we are talking about bipolar disorder. This is the discussion with the expert. And today, we're going to talk about a couple of commonly delved into questions around bipolar disorder, and we'll basically feature kind of like Q&A where we'll talk about the question, we'll answer those questions for you, and then after we answer those questions, we'll open up discussion, and then we'll explore some of the questions if you guys have any that you post on the YouTube channel at the end of the discussion. Our first speaker is Barbara, and she is with us from Uganda, right?
Yes.
And once she starts to talk to you guys, she'll kind of explain to you what bipolar disorder is, and she'll kind of differentiate between the different types of bipolar disorders. But it's really important that we address this topic with the uprising attention that it's getting currently in the media. And we're really excited to present to you guys about this topic today. So with that being said, I present to you Barbara Mutebi.
Yeah. Hello, everyone listening. My name's Barbara Mutebi. I'm Ugandan. I have a diploma in education. I have a bachelor guidance and counseling. I have a master's in science clinical psychology, and I'm a PhD student. I work with children and adolescents, and I also work as an addiction specialist. Yes, I work with schools in Kampala, Uganda, and I also work with Mania Rehabilitation Center, Kampala, Uganda. There I work as an addiction therapist. Yes, I'm also a founder and director of Amani Psychotherapy and Advocacy Center, Kampala, Uganda. Straight to my presentation. The question is, what is bipolar disorder? I did some reading, clearly what is in DSM-5, and it is very clear that bipolar is also formally called manic depressive illness or manic depression. It's a chronic, or it can be chronic or episodic. And of course, this one means that it occurs regularly or occasionally according to in form of intervals. This mental condition causes unusual shifts in mood, energy, activity levels, concentration, and the ability to carry out day-to-day tasks. We have 3 types of bipolar disorder. All the 3 types involve clear changes in mood, energy, and activity levels. These moods range from periods of extremely up, elevated, irritable, and energized behavior. These are also known as manic episodes. You'll find that somebody is down at a certain time Then another time they are really sad. Sometimes they feel indifferent, and another time they feel hopeless. These are all known as depressive episodes. We also have less severe manic periods, and these are known as hypomanic episodes. Now, straight to the types, we have bipolar 1 disorder, we have bipolar 2 disorder, and the cyclothymic disorder. The bipolar 1 disorder, this one is defined by the manic episodes that last at least 7 days, or by manic symptoms that are so severe that the person needs immediate hospital care. Usually, these are depressive episodes, occur as well, typically lasting at least 2 weeks, episodes of depression with mixed futures, having depressive symptoms and manic symptoms at the same time. All these symptoms are possible. Actually, you'll find that people who have got this bipolar 1, by all means, they'll be taken to hospital. At least they're usually taken for inpatient immediately. The person is maybe too hyper and no one can intervene. So what the family does, the first thing is take them to hospital in whichever state. Then the bipolar 2 disorder, defined by a pattern of depressive episodes and hypomanic episodes, but not to the full-blown manic episodes that are typical of bipolar 1. Then the cyclomic disorder, defined by periods of hypomanic symptoms as well as periods of depressive symptoms lasting at least 2 years. 1 year in children and adolescents. However, the symptoms do not meet the diagnostic requirements for hypomanic episode and a depressive episode. Sometimes a person might experience symptoms of bipolar disorder that do not match the 3 categories listed above, which is referred to as other specified and unspecified bipolar related disorders. I work in a rehab, and this bipolar is common among the people who have used alcohol. You'll find the client today is happy and is okay with everyone. The next day, you'll find her in a terrible mood, doesn't want to talk to anyone, but is just complaining about everything. And sometimes they even get violent. So it is a very big challenge. And what happens today is these people are not in the environment, especially with what is going on today. I can talk about what is happening in our country. These people are ignored. They are locked in the houses. They have a safe room where they lock such people up. And sometimes no help is given at all. So these people need attention. And since it's a mental problem, then they're supposed to be taken to hospital where they can be taken care of mentally. A number of times, you'll find these are the signs and symptoms. These people are usually tensed up. Their emotions are, this person who is all the time waiting for what is happening next. Then you'll find that they don't have sleep. You'll find one will sleep and feel like, I should leave this place because for example, in rehab here, somebody is sleeping and says that I am oversleeping, and that is a problem. Then the next day, she says, no, I think I need sleep. So generally, their moods are challenging to the people out there who don't know how to deal with them. So we can say they need help. Then a number of times, they have, you'll find that they've lost interest in particular activities, that you find this person was interested in baking, but no way, she's not interested in anything. Now, when a family realizes there is such a problem, this person needs to see a therapist, needs to see a psychiatrist, but needs in particular help. Then not forgetting that their behaviors usually are, sometimes they are unusual, they behave in a way that is not expected. Like, for example, in our country, we expect women to behave differently. Like when you're greeting, in my culture, a woman is supposed to kneel down and is supposed to be humble. But a woman who is not humble and at a particular age, you have to find out what is the problem. Now, the problem is that when this person is in such a state, people will not take it serious. They will say, no, this one is mad. They've not reached that level. And the only way out is let the family help them to seek for help. So, of course, the mood swings, those ones I've talked about them. They are very clear. Yes, that is what I could get on my symptoms. Thank you very much for listening. Yep. Have a good day.
Okay, and so we'll move to the next slide. And since Raza is the third speaker, I'll talk about the symptoms in a little bit more of an expanded view. Hold on, I'm gonna go back a slide here. So this is actually the third slide. So, so I'm gonna talk about the second slide. So the symptoms of bipolar disorder is actually the second slide. And so she talked about the symptoms a little bit just a moment ago. Because what is bipolar does kind of go into symptomology, because it talks about diagnosing bipolar disorder. And so symptomatology is the right word. And the symptoms of bipolar disorder does go into the diagnostic lens. And so when we say manic episodes, we need to understand what it looks like to have a manic episode. Manic episodes include what we call elevated or expansive moods. And so what that looks like is when people are experiencing excessive goal-oriented activity. And so what that looks like is mood swings, where people are experiencing increased intention towards doing something, a particular goal. And so that person may be interested in doing something, maybe something that is outside of their norm. So maybe they want to go to another state, and that state may be 600 miles away, but that may be something that is definitely outside of their norm. Someplace they've never been before. It could be someplace they've been before, but they know that they don't have the means to get there, and it's not within their budget, and they're going to go anyway. and and they don't have enough gas in the car, and you know, and they're in their panties and bra. And they're just gonna leave, go jump in the car, and they're just going. And those people, they got lots of energy. They've not any, and they are struggling. You know, some of those people may be struggling with anger, mood issues. That high that they're that tangent of high they're going on may sometimes come all the way down to a low. And that's why we say mood swings, because here it is, they're on a high, and now all of a sudden they're struggling with apathy, and they have an apprehension to feel anything. They don't know if they should be feeling for anybody or anything, if they should be feeling good, if they should be feeling bad. So they're feeling a lot of things, and they have a lot of anxiety. It may look like paranoia. They may feel like people are watching them, people are judging them. They may feel like people are on their side, and at the same time, you know, trying to see what they're going to do next, because they can kind of see that they're behaving outside of the norm, but they can't stop themselves. And that's a part of what's happening. That's a part of the problem for them, because they know that there is something going on, but they really can't intervene, and they can't prevent us from doing what it is that they're doing. A lot of times that includes a reduced need for sleep and a loss of touch with reality. And so the depressive that they oftentimes experience in that moment include low energy or motivation to do the things that they typically like to do in their daily activities. They may not want to conduct personal hygiene, brush their teeth, wash their face, take a bath, a shower. Oftentimes they may feel like they want the end of their being to become a reality for them. So those suicidal thoughts and ideation, as far as their behaviors, risky sexual practices, playing in traffic, being extremely aggressive or agitated, starting to cry, the blue, being very hyperactive, impulsive, cutting. What are some of the things cognitively? Delusional thinking, a lack of concentration, intrusive thoughts, false beliefs in superiority, even inferiority. What are some of the things? Agitation. I talked about paranoia. Sometimes weight gain and weight loss in excessive amounts. The sleep part. I always assess for sleep when I'm dealing with people who are struggling with bipolar disorder, because notice that they're going to have a manic episode by way of that sleep pattern being disturbed, because they're either going to be far off by way of not needing any sleep or getting too much sleep. Oftentimes, you also notice that their speech becomes very disorganized or rapid. And sometimes they just speak in a frenzy, you know, pressured speech. And sometimes it's just the rambling, you know, it's just any and everything just coming out there. And you're like, what's going on here? You know, it's just a flight of ideas. Everything's just coming about everything and out of everywhere. So you can make sense of what's really going on for them. And their reality is every reality. And it's from everywhere and from every direction. And some of it is sensible, but some of it's really not. And a lot of people that in order for a person to be bipolar, they have to be quote unquote crazy or not make sense. But a lot of what they say can definitely make sense. And bipolar disorder is positioned amidst depressive disorders and psychotic disorders for a reason. And it's because it's considered to be on a continuum. right? Because we understand them to be very much centered and seated in the middle of them. Because what have I talked about? I've talked about some things that are very in features, and I've talked about some things that are very, very depressive in features. And you heard Barbara touch on some things, right? Because they kind of go hand in hand. And when you see them both presenting together, you know you're dealing with bipolar disorder, you know, on a spectrum, whether you're dealing with bipolar 1 or bipolar 2 or unspecified. So that's kind of like, and that's why we talked about what it looks like specifically, the symptoms, because you have these particular things, whether it's behavioral or cognitive or weight or sleep or, you know, as far as the psychological presentation or physical. So those are some of the more specific things. So I'll jump into what happens if you leave it untreated.
Thank you, Dr. Jefferson. Very good overview of mania. I think that one of the things that people definitely miss in understanding bipolar, and I think how people tend to get this persona of like stigma and persons with mental health are crazy or like mad, as we would say in the Caribbean as well, is because of the mania. I think it's that impulse control challenge and the to people nonsensical speaking, but it actually is a lot of sense when you listen to it, but it's coming from all over the brain. So very, very, bipolar is very interesting. We'll talk more about these kinds of things at the end. But my name is Raisa Khan. I'm a counseling psychologist here in Georgetown, Guyana, South America. I did my master's in counseling psych, master's of science at the University of the West Indies, Barbados Cave Hill campus. And so my work here in Guyana, I work primarily with adults. A lot of the times, usually I'll see some youth, some children, because I'm not clinical per se, but because we don't have, I don't think we have clinical psychologists in Guyana, maybe like one or two. We do have clinical cases that come to me, and if I'm competent, I'll stick with them. If I'm not, I pass them on to a psychiatrist. So things like bipolar I have had, and we have to eventually pass them on to a psychiatrist in Guyana because they need the medication in most cases, because the mania is either too intense to do psychotherapy with them, talk therapy, or the depression is just too intense, too overwhelming. And so we do see bipolar in Guyana. We see other disorders, which I'm sure will be featured on this channel at some point in time. But I do a lot of work with like CBT, very eclectic, solution focused, person-centered, humanistic, etc. So my question today to answer, what would happen if left unattended? Now, like, we can imagine how intense this disorder can get just off of what we understood from Barbara and Dr. Jefferson, in the sense that it can get pretty erratic. It can get pretty high, pretty low. The highs are not just always positive. Sometimes there's a lot of irritation, like Doctor said, out of touch of reality. I think that is something in the sense of the overconfidence, or the inability to recognize like time and place, as we would say in Guyana, time and place. You ain't got no time and place. So recognizing those things can become very problematic. So due to the nature of the disorder, a person can experience any of the following things. Severe challenges with work, home, and even school. If you can't focus, or performance is poor, or you're having challenges concentrating, you're going to have challenges with like holding down the responsibilities that you have, whether as a parent or a family member or within the work environment. Another challenge would be poor emotional regulation. We're not really going to see proper emotional regulation because many persons regard bipolar as a roller coaster-like disorder. And so even if the client wants to get their mania under control, or doesn't want to jump in that car in their bathing suit, like Dr. pointed out, it's almost out of their control. And this is why we look at it as a part of or inclusive of the symptoms of impulse control disorders as well. And so the impulse control and the emotional inability to regulate that can make interacting very challenging. You can have great stress is felt, especially during social in situations. So you may not be able to engage with people in conversations because, like Doctor said, your brain is going 100 miles an hour, lots of different thoughts, lots of overthinking, lots of paranoia. Like, can you imagine trying to have a conversation with someone who has mania? And is having like delusional thoughts or paranoid thoughts. So you definitely are gonna have a harder time even in social situations. We see job loss because of things like performance, but also conflict. So imagine again, if you're in a manic episode and you're paranoid or you have high irritability, you may engage in conflict with coworkers or your boss. And so we can see job loss as a result of this disorder. Persons tend to have limited coping mechanisms anyway. We now see even further reduced or limited coping mechanisms because some of the things that they're going to cope with. So, for example, if they have mania and they want to relax, they might use some substance. And so the coping mechanisms become a little bit more limited because they're not able to focus or regulate. So when we're trying to do therapy with someone who's manic, it's very difficult because it's not in their control. So how do you tell someone who has mania, okay, so we're going to do 4-4-4, we're going to do a breathing exercise, or you're going to do a grounding exercise? It's very hard to give them certain types of coping mechanisms, or even the coping mechanisms that are geared towards like rational thinking. If you have mania or even depression, you're probably not going to be able to do like CBT or REBT techniques where you have to use cognition. We might even see some psychosomatic episodes or effects in the sense that persons may suffer from aches and pains, they may have headaches, they may have even IDB. If your mania comes with high levels of anxiety, or just happens that you have depression and anxiety coupled with the bipolar disorder, you're probably going to experience some kind of irritable bowel syndrome as well. So there are some psychosomatic effects that can happen as a result of this going untreated. And I've had clients come in and say, yeah, I have this irritable bowel syndrome, and it wasn't bipolar, but it was really anxiety. And it was actually an anxiety rooted in a trauma. And so then the IBS becomes present as a result of that. Naturally, strained interpersonal relations, it's going to be hard whether you're having mania or the depressive episode to engage in social interaction, speak with people, connect with people, be vulnerable with people. If you feel like how Barbara spoke about how like in her country where they kind of just lock them away, yeah, you're going to have a hard time with interpersonal relations. If there's conflict or arguments or alcoholism, we're going to see the presence where people cannot have healthy relationships with those persons, and those persons themselves find it hard to open up or be vulnerable or even find the cognitive balance to be able to sit down with someone and explain, this is kind of what's happening to me. Like Doc said, we know something is wrong. Sorry, as Barbara said, we know something is wrong, but it's like, how do we treat with it? Because of this, we're going to see increased isolation and loneliness. Dr. Jepson was talking about how we're seeing an increase in bipolar and schizotypal disorders during COVID. And I think that the isolation due to quarantine and self-isolation that we have had to do has definitely awoken a lot of people's mental health challenges. At least in Guyana, they have. And so, especially coupled with the fact that one of the very common coping mechanisms in Guyana is drinking, and now you've closed up all the rum shops, you've closed up all the beer gardens. And so we have this now increase in also domestic violence. So there's a lot of things that can happen due to COVID that can heighten our mental health symptoms. With this, we have an heightened depression, anxiety, and of course, sometimes we are seeing increased suicidality. As I mentioned before, someone, again, if not treated, they may try to self-treat themselves. And if it is that they have mania, maybe they'll try and drink alcohol to calm themselves down or put themselves to sleep. Same thing for marijuana. If you have depression, you might try and use some uppers. So you might even misuse other actual medication to break away from the mania or break away from the depression. So very common. We then have, with the mania, this like doctor said, heightened activities or heightened stimulation in the sense of overspending, risky sexual behaviors, and those things come with consequences. So we see persons also go in debt. Some persons we've heard cases of people selling their house, selling their car, selling their business in the span of like 3 weeks during a manic episode. So this can be there's a lot of long-term consequences to mania in the sense that we might have debt with risky sexual behaviors. You might have pregnancy. You might have STDs as a result. You might have legal troubles. If you're always manic and irritable and get into conflicts, you might become agitated to the point of getting in an argument or a fight with someone, or in a physical fight with someone. That may not have been your intention, but you provoke someone on the corner while going to the shop and something may happen, right? So definitely legal troubles can be a part of that. You may also see a potential in an increase, I spoke about this just briefly, domestic violence. And this really is seen because with increased mania and irritability and risky behavior and impulse control, coupled with, say, things like substance misuse and abuse, there tends to see an increase in domestic violence, whether you as the perpetrator or you as the victim. So we do see that in cases. And like Doc said, definitely weight regulation. You're not going to be able to regulate your weight if you can't regulate your sleep, your eating patterns, your quality of life, your quality of sleep. And so you're going to see more than likely either a fluctuation, which can then lead to things like body image issues. So it's a whole host of things that can happen if bipolar goes untreated. Now, this might be the same for other disorders as well. Some of these things are definitely seen in other disorders, but I just wanted to hopefully get across the whole spectrum of things, a whole list of things that could happen if bipolar in particular goes untreated. I hope I got everything. Definitely, I encourage my group members to jump in and add on this area, this question in particular.
I think you did an amazing job at expanding on things that happened if you leave bipolar disorder untreated. I want to add to that, it's really important to address your mental and your emotional health needs and your behavioral health needs. So if your family members are saying to you, I'm noticing that you're a little bit off today, I'm noticing that you're a little bit different today. I'm noticing that things with your anger, your moods, things with your weight, right? Anything with you is off. I think that you need to see someone. It's worth you checking it out, because at the end of the day, if people that you trust are saying that they see something maybe a little bit off, it may be. Or it may be worth you exploring the possibility of things being off. Because at the end of the day, even if things are not necessarily off, why not check it out? Right? And feel like she touched on some of the things that are important for us to make sure are checked. These things are checked in our lives on a regular basis anyway, even if there is nothing going on, even if it's nothing wrong, right? And so she touched on some of those areas that keep us balanced as human beings. Did you have anything that you wanted to add, Barbara?
We have, as we speak,
You're muted again.
yes, as we speak, we have many cases of suicide during this period. And you realize that people don't know that when somebody threatens that I can do something to myself, I can take my life, that is not supposed to be taken as, this person is joking. Something has to be done. When somebody threatens that they could take their lives, they could commit suicide, something has to be done, because you realize people are not working. Those who are earning a living, taking care of their families, it's no longer possible. Like Reza, the previous speaker said, yeah, that this is a time people are supposed to be, engaged and doing something, but look at this situation where no, you're not leaving the house, you're not doing any work, you are at home. The wife asks you for maybe sugar, you have nothing to give them. Now, what is going to happen to this young man who had a bipolar situation? Maybe in the past, it was not even recognized, no one diagnosed it, but it's now coming up and nothing can be done. When they threaten that, I can do something to my life, I can take my life, something has to be done immediately. Let's not take things for granted. We have many suicide cases that are happening during this time. People are disgusted with life. And we don't know, because people have not gone into the diagnosis of, Barbara, do you have this mental condition? So-and-so, you have this mental condition. No one has gone into that. So a lot needs to be done. When we see somebody presenting some particular symptoms like the ones that doctor has and Rayaz has mentioned. Thank you.
And so another thing that I wanted to add to this, okay, with bipolar disorder, the one thing that a lot of people have not really paid attention to, with bipolar disorder being squeezed in between depressive disorders and psychotic disorders, the way it has in the DSM-5, with it's being done the way it is, and being with us now as professionals in psychology, seeing it on a continuum. If it's left untreated, what happens with a continuum? And the reason for the word continuum, it means that it evolves from one state to the other. We leave that disorder untreated, it evolves into the next phase of development. And so it moves into a more severe psychotic disorder. So what's on the part of the psychotic spectrum? So delusional symptoms are featured in bipolar disorder already as manic symptoms. So those people become more delusional. They become more agitated, right? Their mood becomes more severe. They become more aggressive. And so eventually they become the people who now hallucinate more. And so now we have a diagnosis of schizophrenia. And so at the end of the day, what was at some point bipolar disorder is now schizophrenia. And so, and we treat it very similarly because we oftentimes use Depakote to treat bipolar disorder, and we use the same medication to stabilize the moods and also to alleviate the symptoms of the psychosis of those who are struggling with schizophrenia as well. So I think that's something to consider as well. So we'll move into the next topic. So how is bipolar disorder diagnosed is one that I figured Barbara would discuss since she took the first, and the next piece was mine, I believe. And she already about that piece, but Barbara, I'll let you talk about the diagnostic criteria since you've already, and she's already kind of expanded on these particular pieces. But she's already kind of talked about the different types. She's talked about the different bipolar 1 disorder. So I'll just let you kind of expand again on the specifics of and differentiate between bipolar 1 disorder, bipolar 2, and the unspecified, because you did talk about these already in your initial discussion, but we'll let you just basically talk about the diagnostic criteria in the DSM of differentiating. I'm going to mute me in just a moment.
Yes. The bipolar 1, sorry. Yes, bipolar 1, it's defined by manic episodes that last 7 days, or manic symptoms that are so severe that the person needs immediate hospital care. Usually these are depressive episodes occur as well. These are typically lasting 2 weeks, so they can also last 2 weeks. They also have mixed features, and these ones, that is the depressive symptoms and the manic symptoms at the same time. So that is the bipolar 1. Then bipolar 2 is defined by a pattern of depressive episodes and hypomanic episodes, but not the full-blown manic episodes that are typical of bipolar 1 disorder. Then the cyclothymic disorder, this one also is defined with periods of hypomanic symptoms as well as periods of depressive symptoms lasting for at least 2 years. It's 1 year in children and adolescents. However, these symptoms don't meet the diagnostic requirements of hypomanic episode and depressive episodes. Then, in addition to that, someone may experience these symptoms of bipolar disorder that do not match the three categories listed above. So it is very clear that if somebody is in such a state, step one, a lay person out there, you may not be in position to distinguish whether it's bipolar 1, bipolar 2. What is important is this person has to report to a medical facility, and it is the psychiatrist to do the diagnostics and tell the family that this is bipolar, or this is bipolar 1, this is bipolar 2. Besides, is to help her or him in the medication that is supposed to be given. I don't know whether I've done it well. I was not prepared for that. Thank you. I go back to you, doctor.
Oh, no, it's fine. So originally we had a different speaker for that particular question, so that for our viewing audience, so they're aware that. So Barbara was definitely caught off guard. So she kind of winged it. So you guys know. So basically, I think you did a great job, but you did touch on it. You definitely covered it in your question, because so there is a difference between bipolar disorder, psychothymic disorder, and bipolar 2 disorder, and other specified bipolar disorders as well, unspecified. Because here's the thing, there are different disorders on this continuum. When we talk about bipolar, it looks different. When we talk about the manic disorder, the hypomanic disorders, the hypomanic features, and we talk about, because when you're having an elevated or expansive feature, bipolar, it looks very different than hypo or under. That's what hypo means. Expansive features. So it means that you're having depressive types of symptoms versus features, hyperactive features, right? Where you're having increased mood and elevated mood and very intensive moods where your impulses can't be controlled. We want to do something goal-oriented type of activity. And so what that looks like is you're really having the intent on going and pursuing things. And you're doing that in a way where you really can't be stopped. You ever seen a kid on the sugar high, right? You can't stop them. They're on constant go mode. And so that's basically what that looks like. And that's very different than a person that's really, really depressed. Well, I shouldn't say that, because some people who are depressed go on extreme spending sprees. So this is what I'll say.
The person that's depressed. Coping mechanisms.
Right. So because when I'm having a depressed mood, I want to make it very clear, I spend a lot. So so a depressed person who doesn't want to do things that they normally do, right? So those very lows, those extreme lows, right, that people feel when they're depressed. So that's the difference, okay? And so the highs that people experience are different from those bipolar episodes that are lows. And so we want to make it very clear that bipolar disorder can look very, just like depression can look very different, which is why depressive episode and the disorder of depression can look very similar to bipolar disorder as well. And we'll talk about that one in the last question in a moment. But right now, we're going to delve into my question, which is, what is the treatment of bipolar disorder? And very similar to what Riza Khan talked about in her question when she talked about what happens when bipolar disorder is treated. When people are experiencing a manic episode, or when people are experiencing an episode associated with bipolar disorder, period, they're not necessarily in a state of being. And what happens is that their rational mind is not here because their temporal lobe loses all of its functional beings. Capacity for rationalization is completely gone, right? So whereas they want to rationalize, whereas they want to be in control, whereas they may want to be able to read and comprehend and process and all of these things that the temporal lobe of the brain is responsible for, the amount of oxygenation in their brain is limited. And so it throws off the chemical balances in the brain, which is what causes bipolar disorder. And so what has to happen is we have to balance that. So typically what happens is we deliver what we call mood stabilizers. Mood stabilizers could look like lithium, could look like sarcosine, if we're talking about something a little more natural. Could look like Depakote, and some people use Zyprexa as well. So it's a lot of different pharmaceuticals and natural means to delivering stabilization. Ashwagandha is an amazing holistic option. 5-HTP is an amazing natural herbal Ayurvedic cure as well. So there are lots of means that are natural ways to balance out that brain chemistry. But what I always tell people is making sure that what you're putting into your body is beneficial to your body. Everything starts in the brain. Your brain is responsible for every single function of your body. Everything. Oftentimes, you don't realize how important it is. So your neuroplasticity is responsible for everything that happens at every single phase of your body's development. So you have to protect it. So that means you need to have a balanced diet, an organized sleep regimen, organized sleep patterns, organized eating patterns, organized thinking patterns. So means limiting alcohol consumption, right? So everybody's heard the wonderful tale that you need to have a nice glass of wine to balance out and to encourage your heart to be healthy. So that means you limit how much you put in your body. So just have that one very small quarter glass of wine a day. That means not the whole glass full, right? Don't get drunk. Making sure that you're giving yourself 8 hours of rest time that's allowing you 4 to 6 full sleep, uninterrupted sleep hours a day, right? Making sure that you're dedicating a specific sleep regimen, period, every day, which is the same time a day. Giving yourself specific hours of the day to eat so that your body recognizes that this is the time for me to eat. Making sure that your body recognizes that there are specific hours of the day that is sleeping. Routine is everything. Your body has to recognize that there are routines that are to be respected. In order for your neuroreceptors receive information and process information properly. And so, in order for your neurotransmitters to transmit information and your synapses to operate properly, you have to calibrate that brain energy properly as well. Everything that you do to manage and to properly execute the processes in your brain have to be reflective of you caring for it properly. So you have to do what you have to do for your brain balance. So what we know is that we have to take care of ourselves. Psychotherapy and nutraceuticals, pharmaceuticals combined is what we use to treat bipolar disorder. A combination, because what happens is an increased amount of stress is what throws further off the balance of those chemicals in your brain. Dopamine, serotonin, norepinephrine, oxytocin, those brain chemicals being offset are the areas of the brain that are struggling when people are having these psychotic breaks. So we'll move on if nobody else has anything else to add. Oh, I didn't add the exercise regimen part. Barbara, Razan, you guys got anything?
Yeah, no, Dr. Jefferson, I was going to say that it's really important to have that holistic approach to treatment, because I think that it can be really overwhelming, especially when persons are now like recognizing that something is happening and they're that in that kind of pre-contemplative state of, should I call, should I find out, should I ask a doctor? And I think that can be seem very overwhelming. And then when they come, we then have to kind of decide, okay, what needs to be treated like immediately. So where I usually start with is like symptom management at minimum, right? If we can get the symptoms to be reduced to some degree, then we can start working on other things. And then like the next stage would probably be like, okay, the eating, sleeping regimen, self-care regimen that are healthy. And like I said, because I'm not a psychiatrist, I don't deal with medication. So they're probably going to be also seen a psychiatrist for the medication related aspect. And so, for example, if they have mania, they'll do the psychiatry side first until they can bring those symptoms down so that they can then engage in psychotherapy or talk therapy. All the while, we might even bring on, say a nutritionalist, say this is someone who has weight related issues. Of course, it would be ideal to have a institution that does all of this. We don't have, say, an institution that does all this holistic. Okay, so a psychiatrist is on hand, a psychologist is on hand, a social worker is on hand, and a nutritionist and a life coach is on hand, right? So what ends up happening is I, as a psychologist, I take on the social worker role, the nutritionist role, the life coach role, which is fine because I am certified as a life coach and I am certified as a social worker, so that's fine. But as, say, a psychologist who doesn't have social work background or didn't do nutrition or didn't do these kinds of things, it becomes very daunting because now we have to refer out our client, which of course can make it very difficult for them to decide, okay, well, I don't have the finances for all of this. So what can I really just do to minimize all of my symptoms? And that's why, like in Guyana, we fall back a lot on the psychiatrist for medication. And then they may see a difference, but they're still having challenges with like maybe the sleep. So if they're not seeing a psychologist who's going to create that routine with them or create that, those charts with them to encourage them to eat on time and sleep on time and self-care, and recognize triggers and all these kinds of things, it's going to be still limited because the psychotropic can only, at least as a psychologist, I'm biased, psychotropic medication in my world can only do so much. At some point in time, we have to talk about like what's happening and what, like,
Right.
where did it start from, right? Like I tell myself I'm not Freudian, but I'm a rootist in the sense of I want to find the root, right? And so my clients laugh at me. They're like, "Oh, we're finding the root today, right?" So I said, "Yes, we're finding the root today." So we do definitely have to look at it as a holistic, because when we look at what happens when it goes untreated, there's so many other things we have to make sure that we're still keeping in consideration, and further trauma sometimes that can happen as a consequence of some of these behaviors, like the trauma of selling your house, an unwanted pregnancy, that kind of thing. So then we also have to treat with that as well. At least that's what I've seen in Guyana. We have to treat with the trauma that comes from impulsive behaviors.
Right. And here's the interesting thing. I don't believe in because here's the other thing. The other piece is that when you start to look into psychopharmaceuticals, a lot of them, when you look at the side effects of psychopharmaceuticals, those chemicals will cause an offsetting balance inside of the brain versus using some of the nutraceutical options for treatment. Personally, I'm a holistic practitioner. I believe that you should always look to the Ayurvedic options and in helping, because what happens is those things allow the brain to naturally balance itself, recalibrate itself. So all of those things that I named are natural ways for the brain to recalibrate its own energy. And so it gets the oxygen flowing in the brain right way, in the right direction. And I also heavily believe in SPECT scans as confirmation of diagnosing. And that's the only truly see what you're really working with diagnostically. So I believe that being bipolar disorder means that you're recognizing what's actually going on in the brain. You see where the lack of energy and oxygen flow is, and that you're helping people recognize not only the symptom, management, but you're also recognizing what's preventing the sleep, right? And so managing proper sleep and sleep regimens means that we've already identified what's preventing sleep. We've already introduced better sleep patterns. And so melatonin is a natural sleep aid because it's not actually the chemical. It's something that helps the chemical produce itself inside of your brain. Right. And so it's a natural sleep aid for that reason. And so it's just giving your brain a boost to produce melatonin within itself. And so that's why I feel like it's really important to help your consumer to better conceptualize what's going on within their own brain so that they can help themselves come to a better sense of understanding what's going on with them so that they can recalibrate their energy and living their best life, because the best version of their life lies ahead as long as they can acknowledge what's going on with them. Because with understanding what's going on with them, that's when things spiral. When they're living in this world where the world is labeling them as bipolar, the person is never bipolar. The person is a person, whomever they are, struggling with the symptoms of bipolar disorder. And so what happens is bipolar disorder is affecting them and they can't get back to their best life because the real problem is that they have inadequate coping mechanism, skills that, in response to stress. So we need to learn how to better respond to. That's just what it is, Out of so new developments in this world, we're maladaptively coping with the distresses that life has, given us. So that's just what this is.
I would like to say something under psychotherapy, because that's where I belong. I think it is key and very important to bring the family on board. Family therapy is important when dealing with such clients. That the family, if it's educated and is aware of the symptoms, is aware of the signs, and the treatment that is given to them, they're also on board that this person needs enough sleep, because it's not that this person, if put in inpatient, is going to remain inpatient forever. There's time when they have to leave hospital, and some of them can stay out of hospital as long as the family is on board. That their eating patterns are monitored, like Dr. said. Their moods are also monitored. So you'll find that if the family is on board, and the family also needs to be helped to clear the environment at home. You realize that many of the clients we handle, if we don't bring the family on board, then you find that you're doing nothing, because the client is going to go back to the same environment and it's where they belong. So the family, the environment where this client is coming from also has to be addressed. Thank you.
I agree. I agree. As a systemic practitioner, I agree. I think that your entire system affects not only your treatment, but also the diagnosis itself. I think that everything starts within the system, not only your internal family system within yourself, but also your external system that you're connected to. So this question, right, it's going to be yours because you're at the end here and we don't have this person. What is the difference between bipolar disorder and depression? What is the main difference, should I say?
Is this me? Or Barbara?
You.
Oh, right. So I think today we talked, I think, a little bit extensively more about the mania. And I think that, at least from my perspective, for example, someone can come in presenting with depressive episodes, and until we start asking about certain behaviors or recent events or interpersonal relationships, or job history, we might then start to see a pattern of instability. And so for me, it is the because you can have job loss obviously too with depression, but I would probably look at it very multifaceted to see, okay, are there times when you feel like there's things that are not in your control, or that you're doing things and your impulse control is not, like, people have come into me and say, I need therapy because I don't like the decisions I'm making. And I would be like, well, elaborate on that. And then we recognize, okay, it's not mania per se, but it's related to alcohol use, and alcohol use geared towards whatever reason, multiple reasons, social grouping and low self-esteem and so on, coping mechanism. But for me, it is the presence of the mania. Even though you said, yes, people can go overspending when they're in a depressive episode, a depressive state. But for me, I'm looking for erratic thinking, delusional thinking, erratic behaviors. I'm looking for those kinds of extreme. Now, of course, we already said that you may not see those extreme thinking unless it goes untreated for a long time. But the turnover, for example, in my case, in my country, people don't come to the therapist until they're in their 20s, 30s. I have clients in their 50s who are coming to me now for the treatment for the first time, really ever, and continuous treatment. And so by the time they come to my office, they are already untreated bipolar for several years. So the mania is a little bit more obvious. So in my case, when I think of the difference between bipolar and depression, is the presence of mania. And like in the case that you mentioned, Dr. Jefferson, in terms of if I'm uncertain, I send them for a brain scan. Now, I can't read the brain scans, but we have a psychiatrist here that reads the brain scans. So we will then work together to be like, okay, well, what is coming up on the scan to suggest, is it bipolar? Is it depression? What is happening? So I think that even in some cases, for example, I've had clients who talk therapy has helped, but it's not helping enough. And I've said, look, I think that this might be a biochemical thing. Let's see if we can go on maybe some St. John's wort. So that's what we use in Guyana for supplement, natural supplements for mood improvement. And so I say, okay, let's try some St. John's worts. And I actually did this recently, and the client said, I don't know if it's a therapy that's working, or if it's just been a good week, or if the St. John's worts is working already. And it was like a week, maybe two after using them, like a week. So, and they also have another disorder as well, that makes their mood very difficult to manage. So they're like, I'm not really sure what it is. And I said, well, keep on the St. John's worts. Let's see if it changes. So it really is very, I think in the beginning, when someone's not presenting as manic, that it can be very much, you can be misdiagnosed with depression very easily. So it is about looking a little bit deeper and looking at their interactions, their relationships, their spending, their coping mechanisms, biochemistry, their history in the family. Did your mother have erratic behaviors as well? In the environment, like Barbara talked about, very important in Guyana. I always tell people, you're coming to therapy, I'm filling you up, and then when you go home, it's like the bucket we just spent all that time filling up has a hole, because you go right back in that environment that triggers you, that overwhelms you, that depresses you. So very much looking at the environmental factors is how I guess I would tell the difference between bipolar and depression.
Okay, so I agree. I think the main difference, like you said, is definitely the mania for the most part. When we think about depression and we think about bipolar disorder is kind of housed in between depression and psychotic disorders, because it's a combination of both. It's a combination. And so mania has to be a proponent. And that's one of the main things that Barbara mentioned, and that's one of the main reasons. With depression, mania is not required, right? So although the mood may be extremely low on a person, and it may look like depression, right? And they may still be very irritable, which we can see in people who present with depression, dysthymia. They don't present with mania, right? They're not manic at all. And so that's the main difference. The main difference is that there are no psychotic features with people who are experiencing depression as well. So we won't see a combination psychotic feature type of thing that happen with people who are experiencing depression. So although there are depressive symptoms and depressive episodes that may present as a proponent of people who are struggling with bipolar disorder, the manic episodes you won't see in people who are struggling with depression. So Barbara, did you have anything to add? Because you'll even see the sleep and the eating, all of that stuff is pretty much synonymous in the two.
Right, and that would tap into what you were saying, like when you were talking about, oh, you'll still see some irritability and depression, and that made me, I was thinking, yeah, you will see some irritability because people may not be sleeping well or eating well or oversleeping and not getting what they need to get done. So then they feel like a backlog of stuff and they get overwhelmed, and if they're not coping well, or if the family is not dealing well with those symptoms, yeah, we can see the irritability as well. And this is why I said it gets, like, someone will come in and they seem depressive, and then like give them a couple of weeks. If they cycle into a manic episode, then that should be the giveaway as to the difference between the two. Because eventually you'll have to cycle into some type of hypomania, mania kind of situation.
Right, because the thing is, you see people come in with and that's the thing with not only just those, but there are a lot of diagnoses that we send patients for rule outs on. And that's the thing about differential diagnosing. We have to do that because a lot of diagnoses look like all of the rest of them. They all look the same, and there may be one or two things that are key features that we attribute one diagnosis and not the other, because they can't be all. We can't who is diagnosed with every single diagnostic code in the DSM. And so we have to look for those key features that differentiate a person from having this feature of this diagnosis from this diagnosis, because that's why we say a person must have 5 criteria met, 6 criteria met, all criteria met, and there must be no trauma history, no cultural factors, no other medical conditions, no other things that justify the symptoms. And so these are things that we as clinicians look at when we're attributing a diagnosis to an individual that are struggling with particular. And so when we look at bipolar disorder and depressive disorders look very similar to bipolar, because bipolar disorder, very much like depression can look very similar on the highs and the lows, right? And so what we've learned is when we have psychotic features, because anxiety is a proponent of bipolar disorder and depression. The mania is the thing that we want to say, okay, it's the huge proponent that separates the two. The psychotic presentation, some of the behaviors may be the same, the weight may be the same, the cognitive distortion, disorganized thinking may be the same, because some people that struggle with depression may sometimes also find themselves very confused, presenting with pressured speech, disorganized thoughts, but they are oftentimes not just delusional. They're not just all the way out there and out of touch with reality. They're just, they're not the same as who's struggling with bipolar disorder, But so that's that part. Let me see if I can get out of here. So open discussion. I'm going to try and see if I can close this part out and go over to our here and see questions from our YouTube. We still have a couple of viewers over there. Don't have any questions. So on the YouTube, you guys, do you have any questions for us? I feel like we covered things pretty thoroughly, ladies.
Let's hope so. That's usually what I tell myself. If there's no questions, we've done a good job at clearing everything up.
Doesn't appear that they have any questions. But so I want to thank you guys for your contribution. And we've recorded this, so you'll see this on both YouTubes. You'll see it on mine, and you'll also see it on International Women in Psychology's YouTube page as well. I'm sure that Bhumika will go and do her or whatever she's that stuff. I'm not. Mine is just what it is.
It makes it into a whole show.
Exactly,
like, suspense music and everything, and I'm like,
right. I'm like, how are you doing all of that?
Yeah, psychologists, some creative people, you know. I'm very impressed. Very impressed.
So we do have one question. So he says, can bipolar be cured? So that's a really great question. And so the let me see. Way to answer that. I'll say I've seen a patient with bipolar disorder. The longest time that I've seen a person without symptoms that I've treated personally, it's been about 13 years without an episode. So I don't know whether or not you can call that cured. I can say that's without symptoms.
I was gonna say, depends on what we're deeming cured.
Mm-hmm. So a person's perception of cured is, I think that everything is a perception. Perception is reality. That individual may feel, and to this day, when we have conversations, when we have sessions and check-ins, because they kind of just check in. Now I see them every 6 months just for a check-in. And this person only just takes, he's an Ayurvedic person, so he just takes supplements basically. So just vitamins, and he checks in every 6 months, and he's balanced. And yeah, no, I feel like he feels like he's cured, but for me, I feel like he's just well balanced, and he takes care of his emotional, mental, and behavioral health, and he makes sure he remains calibrated. He uses his coping mechanisms that he's been taught, and he navigates through his distress. So that's something that does happen in his life that causes him distress, right? He calls me and he's like, look, this happened. Is this a thing? And I'm like, do you think it's a thing? And so we kind of navigate what that looks like for him. And so we process it in therapy. And typically in a week or two, after a couple of sessions, he figures, okay, well, yeah, I'm in a good place. So he no longer needs a session. He moves back to his regular thing. And before you know it, he's back on track, doesn't need me, and, checks in his next 6 months. Things are good. So in 13 years, I've not ever seen him have an episode. And when I first saw him 13 years ago, he was in a very, very dark place. Right. And I'm really happy for him. So
yeah. I think we have to, when people ask, can you be cured from something? I think in mental health, we have to acknowledge that certain disorders are going to be like a continuous journey and a continuous effort, because there might be triggers or things that, and I think that like at least in like Guyana, we need to get people, like we're dealing with the stigma, great, it's going along, people are coming to therapy. But the new thing that we're battling as psychologists is you need to understand therapy is a journey. Like I've had people be upset that after 4 sessions, they're not getting better. And it's like, it's a journey. You're coming to me after 15 years of doing the exact same maladaptive thing, and you expect me to whip out a wand and go, poof, you're cured in 5 sessions, papa, and
right.
So I'm always constantly telling them, once I get that first session down and we start setting the goals and stuff, and start thinking about it like that, I'll say like, look, I'm just gonna tell you, like, because people have asked, well, how many sessions do I need? I said, well, until we kind of know more, or until I get the goals, and I can kind of, say. But I remember a colleague of mine, she was like, I was new, I was very young psychologist, and she rushed to say, oh, I'm still young psychologist. And I said, I need his help with this client, da 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 da. And she's like, Riza, there's trauma. Don't call me back for another like 20 sessions. And I'm like, okay, like she's like, you have to deal with all of that before you get to it. So that's what I kind of tell people, that everyone is going to have a different timeline. Like, don't compare yourself to even like your sibling, you know. If you both have similar disorders, you're both going to treat with it differently, and you're both going to take therapy differently. And we could use, we could, use the same kind of profile, same kind of technique, and two different clients, and they're going to respond to treatment differently, just based on their own personality, their own upbringing, their own level of coping, like you said, mentioned earlier. And I think that it's important for clients to know that it's going to be an ongoing work. Just like if you were overweight or you had a heart condition, would you just stop taking your heart medication just like that, or stop going for your walks in the afternoon? Exactly. So I always tell people, I use a lot of medical comparisons. The whole, if you broke your hand, would you not go to the doctor for a cast? So why aren't you coming to a therapist for, a broken heart?
Right. So I feel like, so when you think about it, essentially, right? So when you think about these things, I don't think that mental illness, I believe that there are mental diagnoses that are mental afflictions. I feel just like, so if you think about it from a medical model perspective, when you go to an ER after having fallen off of a bike, okay, and having procured a cut, okay, so we would diagnose you with a laceration, bilateral, okay, and we would stitch you up. We would place Neosporin, right, or type of antiseptic ointment, right, to prevent infection while that heals up. Okay, so consider that diagnosis, the diagnosis of bipolar disorder, and consider the stitching, right? The pharmaceutical or herbal medication that we've given you, and the therapy, and combined with the nutraceutical, or the natural medication or herbs that we're giving you, or whatever medication, if you consider a chemical medication to help stabilize your moods while you're navigating psychotherapy, that's fine too. So those things, right, are your stitches and your antiseptic ointment or whatever, while you're healing. And so when you're done healing, your therapy regimen, your treatment plan, however long that may take, 6 to 9 months, 1 year, whatever you're doing. And then once you're done, once that healed, right, you're out here living your best life. If you feel like you need to continue your herbalistic medication, right? We talked about this particular patient of mine, he may or may not be continuously every day taking these herbs, right? However, what I know for a fact as an outsider looking in is that this 13-year span that I've been seeing him, during his 6 months check-ins, he's always been balanced. His reports from his family system, the people that are connected to him, the reports are that he's always balanced. Oh my God, I don't know what you did, but he's amazing. He's great. His wife, I love this man. He's a new person. Like, he's not had an episode, right? So these things tell me, and I have hundreds of other patients that I've treated, but they have been, now they've not had an episode, but it's been more like 5 years, 4 years, 3 years, but still they have a similar regimen. And for them, they're still on that same, thing, but it's just been less time for them. And the thing is, they've got their balance. They are living their best life. And for them, it may be that they're cured, that they're just without right now. But for them, they're no longer in the place in which they came to me. So even if they were to have another episode, just like if you were to have a cut, wouldn't you go back to the hospital? Right? So even if you were to revisit the ER to get stitched up again, is there something wrong with you? Or is there something wrong with your skin? Right? So it doesn't have to be something wrong with you, but you're currently experiencing symptoms.
Or you're clumsy.
Right. Right. So your behaviors.
Maybe you need to stop riding like Harleys and motorbikes and risky behavior, maybe it's the risky behavior that keeps getting you to the ER.
Yeah, you might need to adapt more, more or less, risky behaviors. Maybe you need to find another hobby.
Yeah.
But at the end of the day, it doesn't mean that there's something wrong with you per se.
With you.
We need to find a different set of options for us to decide to entertain ourselves.
Right.
But so I don't look at it like there is an illness per se. I look at it like there is a problem that needs to be resolved, that's afflicting the person. Right. Barbara, did you have anything to add before we wrap up?
Yes, in addition to that, for me, I want to talk about a client I handled. She was an addict, and this is a young lady of 27 years.
You're breaking up a little bit.
She was brought from school.
Okay.
What about after stabilizing her? Now the challenge is that the family expected us to fix her in 1 month. So when we talk about cure here, we need people to understand this disease, this mental condition. It is not something that you can treat in 1 or 2 sessions and see results. So when people are brought for therapy, they need to understand that mental conditions need patience. And the patience has to come from the family, because the patient may not be in a state of appreciating therapy. So what about the family? So for cure, I, like Doctor was saying, and Reyes, that cure is not something we can state that there is cure, only that the triggers will always exist, but how does the patient deal with the triggers? And the environment where the person comes from sometimes may cause these triggers. Like, where we stay, things will not change. I tell my clients that when you leave rehab, where you left a stool and a flower pot, you'll actually find it in the same spot, in the same corner. It is you to change and totally think of life differently. So the same applies to this mental condition. That it's not easy for us to say that cure, yes, it is known. Only that even for 13 years, someone can stay sober, someone can stay without any episode, as long as life has, there's a change. if there is a change, not only with the client, but with the family, and I'm very sure that somebody can stay for ages and ages without a relapse. Yeah, thank you.
As long as life is happening, triggers can happen and relapse can happen, but it's ensuring that you keep on your treatment or your own personal goals and own personal way of maneuvering through life, basically.
Yes. Yeah.
I don't know what happened to Dr. Jefferson, but I know that we were going to wrap up soon. I'm going to see if she'll pop in before we wrap up. I'm sure she'll be back. But I'm glad that we had the discussion. I know that people will, because I've just shared out the link on my page, on my Naira Counseling Psychological Services page. So people can go back and re-listen and or ask questions on my side. Usually what I do is if I do lives on other people's like forums, if there are questions that we don't get to, I will answer it on my forum. So then I'll do a whole different live by myself and be like, okay, so these were the questions we didn't get to or came up after or later. Oh, there we go. She's back.
Welcome back, doctor.
Okay. My connection went out for a second.
Yeah, we realized. We're like, okay, it's just two of us.
Oh, it's okay. It's still streaming on YouTube though.
Yeah, good. So yes, we were just saying how, how basically the lives was put up like on my page, and any questions that if people still have questions later on, they can post it and I will answer them to my best ability on my page. So people can always check that out as well.
Okay, awesome. So I heard the part where Barbara was saying that she had a patient and they felt like basically the family felt like she could cure the issues that were going on instantaneously.
Right.
And you feel like it takes time, right? So I do agree with that, and I that is another thing that I feel like does need to be emphasized. Yeah. I feel like too often people do not really look at the complexities around exploring the city to examine the severity of the impact of mental illness and disorder in family systems, the way that it impacts the system, and the amount of stress that disorders in general puts on systems. And so we have to look at the fact that it takes a lot for us to support our family members when we're trying to be people who are just there, for those people that we really love, those people that we care about. We have to be the type of people who advocate for mental health and wellness, and in a way that says we recognize that it's important for those people that we hold near and dear to our hearts to get the type of care that they need, but we're patient enough to wait until we have resources and they have resources within themselves and externally rehabilitate self, right? And the system has to be able to support that. So in order for the system to be able to support that, they have to be in a place to receive. And I think those skills have to be taught. So it's not something that's kind of like just natural or automatic. I think it's something that comes with time. And I think the more that we navigate that journey of complexity when it comes to understanding, becoming people that are listening to understand, the more that we navigate that journey, I think the closer we will become to alleviating the issue when it comes, mental illness plaguing our society. Because when we're people who are just listening for an automatic remedy, right? What we're doing, medicating our family members to really silence them, because that's what's happening. I feel like we have removed the infirmaries to replace them with zombies. Like, we're zombifying family members. That's what we're doing. We're asking for psychotropic medications that zombify or the psychiatric wards. What do I used to call them? The mentally facilities for the insane, right? So we don't have the facilities anymore, but we'll have them at home, and we'll zombify them at home, and we'll lock them up in rooms and live our lives out, and we'll isolate them, and we'll wait until those family members commit suicide on our watch, and we'll further traumatize the rest of the family system by exposing them to suicide directly, and we're causing further systemic issues. And we don't even know that that's what we're doing as a society, but that's what's happening. So in order for us to stop that, we have to become people who are accountable and holding ourselves accountable of what we're doing, and reverse those behaviors by saying, hey, we recognize that this is a problem. And because this is a problem, we recognize that solving this takes only accountability, but reaching our behaviors by listening now to understand. And by way of understanding, this is what we're going to do. We're going to now adapt new means of coping by way of listening to what this person needs, by getting out there and exercising with our family member, by watching for their sleep patterns, by watching for what's causing them distress, by teaching them how to deal with rejection, right? By limiting their screen time, because that's one of the things I don't think I touched on. So one of the main things that I do to treat bipolar disorder is limiting screen time. I say to the family members, to the husbands, to the wives, to their phone. Take the tablets, take the laptops, take the desktops, take the iMacs, take the MacBooks, take all. Okay, unplug. You've got to learn how to unplug. Leave Instagram alone. Log off from IG. Log off from Snapchat. I know. I hear all the time. They're like, but Dr. J, you got to understand. I got to be on my memes. And what's the other thing they always tell me? My streaks. And let me tell you, I guess I'm too old. I'm uncool, and that's okay. I have no idea what a streak is. Okay. I'm like, what do you mean, like streaks and underwears? I don't know. And, in my day, that was not a cool thing. But leave the streaks where they are. Okay? Let go of the streaks. Leave it alone. Okay? Pick up a book instead. Do some mindfulness. Right. Go for a walk. Do some mindfulness meditation. Be alone. Find a comfortable silence. Do some silent reflection.
Be okay with being alone.
Yes. And understand that, see, there is a difference. I tell people all the time, there is a difference in shutting the world, okay, and being depressed and isolated, okay? Shutting out the world means you're intentionally silencing.
Cocooning.
Yes, so that you can fine-tune your brain. Being isolated and depressed means that you're unintentionally finding yourself in dark spaces because the world has found a way to shut you out. That's a difference. It's a huge difference. So find a reason, find a purpose, and accepting that silence for yourself. Tell yourself that you're worth it. And find yourself struggling with these crazy pieces of uncomfortable silences that force you into these spaces where you're having these manic episodes or bipolar episodes that make you feel uncomfortable in the first place.
Yep.
You guys have anything else in closing?
I think just encouraging people to be aware. Don't be afraid to ask questions or talk to whomever you're observing stuff happening to. Do your research, see who's available in your country or even online now. And and I always tell people, like, ask questions. I may not be able to be the therapist for you, but I am definitely going to try and support you as best as I can, whether it's referring you to another, like a psychiatrist, bibliotherapy, YouTube videos. Like, my clients get a whole works of things they do and homework and all kind of stuff. So I think that it's important for you to, take that time to be vulnerable, take that time to say, I don't really, and my clients do this a lot. They come to therapy because they're like, something's not right. They're like, I don't know what it is, but something's not right, Riza. And I said, okay, well, let's look at what's happening. And that's how a lot of people end up in therapy, at least like in Guyana, because they're like, something's not right. Like, a normal person should not be thinking this excessively. And what we see a lot of times is not even like it's the sleeping and the eating and the anxiety and the ruminating. They hate that. They hate it. And that's what brings people into therapies. Those physical manifestations, the headaches and the IBS and the pains. And they're like, I just feel broken up, Riza. Why do I feel so broken up? I'm sleeping okay, but I wake up exhausted. Those are like telltale signs, like something is amiss, something is maybe chemically off, psychologically off, and just take the leap to find out what's happening. We're going to try to do our best to support you.
And also, I want to say, stop self-diagnosing. Stay away from the internet, thinking that you're a psychotherapist. Okay?
WebMD.
Oh my God. Stay away.
People come and tell me, I have X. I'm like, how do you know this? Were you diagnosed with something? And then they'll like, they clearly have done their research. And then you have to wonder, are you presenting with these things, or have you done so much research that now you are manifesting it? And so then I have to do all these extra things to make sure you're not just manifesting, because you've done so much research and it's
now you're malingering.
Right. And so you've given me more work now, because now I've got to figure out what's false reality and what's really happening. Thanks, guys.
Right. So please, 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 please don't allow this thing to be psychosomatic. And so we would really appreciate it if you guys did not make our job harder and just come in with what's really presenting. Because like over time, and here's the thing. Oftentimes I used to think for the longest, I was like, man, these psychotherapists are out here misdiagnosing these people sometimes when they come to me. I'm like, no, it's not them. It's these patients. Y'all are out here living your best life on the internet. Yeah. So understand that the internet will never give you a complete resource of information. Because here's the thing, if they did that, then we wouldn't have a job.
Exactly. Everything has to be tailored. Like even when we go on like Psych Point or Therapist Aid and we find exercises and stuff, I still have to sit with it and be like, is this really, like, you'll come under the category of, I don't know, eating, right? Eating disorders. When you scroll in, you're like, but this is not really, my client doesn't have this issue though within the eating disorder spectrum. So never mind, and so it has to be very tailored to each person.
Right. So everything out there has to be fine-tuned. So there is nothing out there that's going to be as comprehensive as actually seeing a professional. So we're professionals for a reason. And so the professionals are professionals because we've gone through extensive training for years and years and years and years. We have decades of training under our belt that makes us that are qualified to do this work. And are tons of resources out there that can help guide you to understanding your diagnosis more. We want you to have those resources so that you can read up and better understand what you're dealing with in the conversations with us. Does that make sense? And so here's the thing. Those resources are to help you understand with the knowledge that we give you, right? So yeah, that part. So do not go out there and think that you know exactly what it is that you're dealing with. I've had so many people come in there. I have schizophrenia and bipolar. I'm like, that's well, okay.
That's a lot.
All right. So what are some of the symptoms that you're currently dealing with today? Well, schizophrenia and bipolar. I said, well, schizophrenia and bipolar are not symptoms. They're disorders. But let's talk about the symptoms of each. And so the thing is, if you have one, you can't have the other. But it's nice that you guys are doing your research, and we appreciate that. So stay away from the internet, please.
Right.
Let's direct it. Barbara.
For me, my last contribution would be, on addition to what you say,
You're frozen
She's
again.
sticking.
Let me see. I mute and freeze me if I can give her a boost.
That's someone was calling, sorry. So I was saying that people out there need to know that therapy is not fashion. It is not style. We need therapy, and each one of us needs therapy. Let's not wait for challenges as big as mental breakdowns. Let us, all of us out there, seek for therapy, and let it be for the whole family. I wish every family had their own therapist. It would really, save us from all these challenges that we are facing today. That's my prayer, that therapy is appreciated by everyone out there. And I think the world will be a walkover. Otherwise, greetings from Uganda. I remain Barbara Mutebi, and I really am really grateful that I was part of this meeting. Thank you so much, Doctor, for hosting it. And Reyes, thank you so much. Have a good week.
Amazing. Thank you so much, Barbara. And I'm going to go ahead and co-sign with her because I think that she made an excellent point. I think that every therapist should have their own therapist, and I believe that therapy is definitely something that works. I have my own therapist. I am an advocate for therapy. I feel like everybody, whether you're going through something or not, should have a therapist because it keeps you calibrated, keeps your life balanced. And that's how you know that you're in check. And you don't want to wait until something goes on, because let me tell you, you're waiting until something goes on. What if you pick the wrong therapist because you're in distress?
Right.
I can't imagine what happens when you're picking somebody just because you're under duress. You're still in a state of disarray, and you're trying to actually select somebody to manage your mental, emotional, and behavioral health care. So I think it's really important to find you someone to help calibrate your energy, to keep your chakras, in alignment. So you're selecting the right ones that resonate with your spirit. But yeah, so I'm a huge advocate for therapy, for mental, emotional, and behavioral health care. And with that, I want to thank IWIP for bringing this topic to the forefront and suggesting this topic, and thank them for the opportunity and asking me to host this topic today. Yeah, that's all I have. Raza, you got anything in closing?
No, I just, like I said, be vulnerable, be kind to yourself, be ready to work, ready to put in that work, mentally, emotionally, psychologically, everything in between, systematically, and knowing that we don't have a magic wand and that the work's got to come from you a lot of times. We're just here to support you as best as we can.
All right, you guys have an amazing day. And thanks for taking out time on your Sunday to watch us. I want to thank the audience on YouTube. You guys have an amazing